inferior superior, anteroposterior, and lateral variations. You see median values and error bars and extremes, because when the measurement is based on 4D MRI scans, you have a variation on the cycle by cycle basis, as we have seen in the previous presentation. So you actually have a range of the amplitude of motion in the different directions. The same was concluded by the Heidelberg group based on 4D CTs. Now, does it have the same impact on carbons and on protons? Well, no. The effect on dose degradation is much higher for carbon ions than for protons, because they have a much steeper lateral fall off, and the spot size is smaller, so it's like painting with a much smaller paintbrush. And this has been measured and determined with pinpoint chambers within an in-house built phantom from Medostron, from the center in Medostron, which is called ARDOS. It's Advanced Radiation Dosimetry Phantom, and it mimics a lung patient. So here you have the patient lungs, and here you have the tumor where you can insert pinpoint chambers, and everything can move basically. So the tumor can move with different ranges of movement, and the lung can expand, and there are also ribs inside here that can move with all the rest. And what you see in the graph is basically the pinpoint measurement. Each color is a different pinpoint for a different combination of movement of tumor, different amplitudes, together with the ribs, together with the lung, or just tumor. But what I just want to point out is that in the tumor and outside in the penumbra region, the effect of dose variation was doubled when they tested carbon ions as compared to protons. And also, the shaded area is the maximum variation inside during day of measurement. So also the variation in the same day is significantly higher. So all this was to say that we actually need motion management techniques for this kind of tumors when we're treating with carbon ions. So what can we do? Well, ideally, my great desire for Christmas would be to be able to do what they are doing in Japan, in the group from Professor Mori, and to do layer phase control rescanning with phase-specific target volumes, and even seeing the tumor while you're treating it. That would be really the best ever, but unfortunately, this is a very unique, let's say, possibility. So here, you have already seen these results, and it's from a feasibility study for liver patients. They were able, I mean, the technique, the rescanning technique, is so good with this synchronization and with this variation of the dose rate in order to have a complete spread of the rescans along the gating window or along a breathing cycle, was so good that they could guarantee target coverage even with just a little bit more than 4 phase control rescanning and just 2 fractions. Because as I said, interplay, it's random effect. So when you treat with protons, you always have this advantage that using multiple fractions, the effect of interplay can be somehow smeared out at the end of the treatment. Not completely, but at least it's fractionation. It's a kind of rescanning basically. But they were delivering it with 2 fields and just 2 fractions. They said that they concluded that the results were good even without gating. Of course, if you use gating, the good point is that you increase treatment time, but you can also spare much more the organs at risk, and particularly the healthy liver, because if you use gating, of course, your target volume will be smaller and it will include less healthy liver tissue. What are they doing in Shanghai? In Shanghai, they propose 3 options. So basically, if the patient can hold his breath, the patient is treated with active breathing coordinator, which is a system that can block your the amount of air that you have inhaled, let's say, in the position, in the reference position. So it can be blocked in maximum inspiration or blocked in maximum expiration, or at a certain point in the middle, but I would say the defined one. So they were using the ABC system. If the patient could hold his breath for like 20-30 seconds at the end of inspiration. If this was not possible, they were moving to gating with the ANZAI system, which is like it's a pressure sensor that you can put, which is we are actually, we should show you a picture afterwards. We are actually putting the sensor under the treatment mask. If this was not possible for the patient, they were using abdominal compression, which is a mechanical system that compresses the abdomen of the patient and reduces the breathing motion. Now, this is a study from the group of Trento, from Francesco Fracchiolla, and I put it here even if it's protons, because they're also using forced breath hold with the ABC, and I think they, not having the possibility of having a daily images and continuous monitoring of the tumor position during the treatment, they use the ABC with, I think, an interesting approach. So under the assumption that they would need more than a breath hold to deliver a full treatment fraction, or at least a full treatment beam. When doing the simulation, they were acquiring 3 simulation CTs in breath hold. In this case, patients were treated in maximum expiration. They used the 3 CTs to evaluate the variation intrafraction of the tumor position and tissue positions during one breath hold, and to define a target volume. And then they were repeating these 3 CTs with different breath holds at the 5th and 10th fractions. Again, this is protons, to evaluate the effect, the interfraction variation. From their analysis, they concluded that the system was accurate enough, and the mean number of breath holds per fraction and per field was around 10 and 2.5, and the median breath hold duration per patient was around 12 seconds. But I think their approach was interesting. So what are we doing for abdominal tumors? First of all, we do a thermoplastic mask, which is a solid mask that applies a mild thoracoabdominal compression. We measured the amount of residual motion after the mask is in position, and we measured the diaphragm motion, variation of the center of mass between maximum exhale and maximum inhale in 27 patients, and this was around, on average, around 5 millimeters, and we did the same for tumor displacement in the gating window, and this was around 6 millimeters. So it already has an effect in reduction of motion. Then after at least 24 hours, we acquire a 4D CT with the ANZAI system in place. So we put it just under the mask because we have seen that it's good enough. We wait 24 hours because the first patients were scanned immediately after the mask. So when the mask was solid enough, like for a head case or not moving case, we were acquiring the CT. But then in the first reevaluation CT, basically everything was shifted up because the mask became tighter and the compression was stronger. So we always found a systematic shift in the imaging. So now we're just acquiring the CT scan after at least 1 day, 1 or 2 days, and this definitely improved our reproducibility. Then we do a 4D robust optimization with ray station on the maximum exhale. We use, I would say, 3.55% range uncertainties and 5 millimeters setup uncertainty, and we include the 30% inspiration phase, reconstructed phase from the 4D CT, because 30% inhale and exhale are, let's say, are the boundary of the ideal boundaries of the gating window. So we try to see the worst case scenario in our ideal gating window. And then I will come back to this part at the end of the talk. Then we do robust evaluation and recalculation on the extreme phases, and we actually do a weekly for DCT to see if everything is fine. So these patients are doing either 2 weeks treatment or 4 weeks treatment. So we acquire a certain number of for DCTs. We are trying to use for the MRIs in order to reduce the dose to the patient. I will show you the results, and then we combine gating with 5 times layer rescanning. 5 times layer rescanning is the best we can do with our machine, and there's no we cannot change the dose rate, so everything is randomly happening. There's no synchronization between the beam extraction and the gating window and the rescanning time. And the final duty cycle is around 30%. So why do we do a combination of the two? Because when we commissioned our gating system, so when we checked if the machine was actually able to chop out the beam when the signal came from the gating sensor, we use a moving phantom with radiochromic films. And here is the static case. This is the case with 7 rescanning. So it was not good enough. This is the case with gating, and here is the result with a combination of gating and rescanning. So we are finally using both techniques together. Then we did an end-to-end test of our system. We actually did it to see if we would be able to treat lung cases, but we actually treated very few of them. We are mostly concentrated in the abdominal region. But anyhow, we choose our few cases and several cases from the literature, for which we had the availability of reevaluation for DCTs. We did for the robust optimization, as I explained before, and then we checked the interfraction variation on the reevaluation CTs. And the important part of this is just the study with protons, but we repeated it with carbon ions. We tested different robust optimization technique. We even tested different spot sizes for carbon ions. And we also made an in-house phantom, which is much simpler than the one you saw before, but anyhow, it mimics a lung with there's water here inside, and those are pinpoints. And this phantom can move with irregular breathing patterns that can change. And we use this to verify that our, let's say, the full system was accurate enough for what concerns those delivery. Now, how do we decide if we need to use motion mitigation techniques? We do a 4DCT to the patient, and then we have everything. Every time there's a doubt, and then we have the maximum exhale and maximum inhale phases contoured. This case apparently is not a case that requires gating, because of course density changing where you have the lever, but beams will be from here and from here, while this case definitely needs gating. So those was calculated on maximum exhale and recalculated on maximum inhale, and there was basically no difference. This patient was treated without gating, while this patient's, of course, the dose distribution is significantly degraded if you don't use any motion mitigation. And then you have to check it again. So we do the planning for DCT, but as we have said before, the breathing pattern is not regular and is going to change. It's going to change during one treatment fraction, and is going to change between one day and the next day. In some patients, it's more stable. In some others, it's absolutely not reproducible. So the maximum we can, ideally, I would like to see it online and while I'm treating again. But the maximum we can do, unfortunately, at the moment with our in-room imaging system, is not good enough for this kind of, it's not able to provide this kind of information. So we check it every week. This is an example of a patient on 15th of March that she had the planning CT, and then we did after 4 days a reevaluation CT, and the tumor was in a completely different position. Those two are maximum exhale phases from the 2 days registered. So this is the same breathing phase. I did just an exercise. This is the plan as it was calculated. And here is the recalculation on the maximum inhale of the same CT. So this is intrafraction variation. And here is the calculation on the maximum exhale of the first reevaluation CT. And as you can see from the DVH, the dose degradation is of the same amount. So if you don't check that it's reproducible, then you can obtain the same level of dose degradation. I just had this slide because the patient came back after 2 years. And so this patient has a, I'm gonna read because oligorecurrent high-grade serous cell ovarian cancer, whatever. I asked the medical doctor several times, and she said that this is not a relapse, but it's a second recurrency from her ovarian cancer. It's a different position. In this time, the patient was absolutely reproducible. So every time we acquire for DCT, this small target on top of the hepatic dome, because first time I saw it, I thought we will never hit it. But every time she was coming back and we were checking the patient, the target volume was exactly in the same position. So as we have said, the 4D CT is just a snapshot of the patient movement in that moment. How can you check it? Well, one solution is to do 4D MRI scans, which is a solution that allows you to have information for a much longer time. So you have several breathing cycle in the acquisition. It's not just few breathing cycle as in the 4D CT with no dose. So you can also acquire 4D MRIs several times without worrying about the patient dose. What can you do with the 4D MRI? Well, of course, you can measure the amplitude of motion from the MRI scan, but you can also build synthetic 4D CTs, which is something that is frequently done nowadays to study the full, let's say, dose degradation from the organ motion. And the way you do it is that you acquire your 4D MRI and then you have your 3D CT or 4D CT. You do a registration of each phase of the 4D MRI and you build your synthetic 4D CT. This is a study from PSI in which they showed those the variation, let's say, of the, as Professor Mori was saying before, the variation of the position of the the center of the breathing cycle, but also the variation of the amplitude of the breathing cycle. So you see the, let's say, the center part is the white line and the amplitude is the yellow lines. And here you see different cycles. So you can see from the picture that can change a lot. They did those calculation for proton treatment, and then they did the calculation in each of this cycle, and then they accumulated those on the first planning CT. And they were actually showing that there was a difference, which is this red part that you see in this gamma analysis. We did the same for 9 of our abdominal patients, the pancreas patients, and liver patients. We every time the patient came to do the simulation, he was then moved to the MRI scan, and we were acquiring, with the same immobilization system, we were acquiring for the MRI scan. We used it to test the tumor movement inside the gating window. And here you see 8 patients, sorry. The green is the gating window is estimated by the for the CT scan, while here you have the organ motion estimated by the MRI. Again, it being having several cycles, you have a median and interquartile variation and extremes of the target motion. So in some cases, from the 4D CT, it's overestimated, but in other cases, it's significantly underestimated. As in this one, this is a case where we completely missed the tumor position. And then we did we also did the dose accumulation and evaluation of the variation, which was, let's say, the average variation on a cycle by cycle basis, cycle to cycle basis. And the system was actually more robust than we thought, because we had median interfraction variation of median interfraction motion of 3.312 millimeters, and the CTV dose variation on a cycle-to-cycle basis was around 4%. We didn't have significant variations on the organs at risk. Probably because when we plan a treatment, we are much more conservative on the organs at risk than on the target coverage. The last thing I want to mention about organ motion and respiratory motion is for DDoS tracking, which is also something that it's becoming more and more common nowadays. There are several studies which has been published for different districts. One of the recent one from Barbara Knoss from Meadowstone. They studied the proton treatment of pancreatic tumors. What is for DDoS tracking? It's basically a reconstruction of the real dose delivered to the patient based on treatment log files. So log files from the machine, from the dose delivery system, which tells you where particles were actually delivered, synchronized with the breathing signal, so that you can know in which breathing phase a certain spot was delivered. And then what you do is, so ideally, you should also have a real-time imaging of the patient. The weak point is that you have to use the most recent 4D CT that you have, the most recent 4D imaging of your patient. But what you do is basically assigning the spot to a certain phase, and then calculating the dose on the corresponding reconstructed phase, and then accumulating back on the planning phase all the different partial irradiation. Then you do accumulation of all the fractions, and you end up with a final cumulative dose distribution, which should be much more similar to reality than your treatment plan. This has been done for protons. It hasn't been done for carbon ions, because for carbon ions, there's the drawback of RBE calculation, which is not linear with the dose. So all the calculation of the partial, we cannot just calculate the partial of each on each treatment phase and then sum it up. And now I have a few slides on the other problem, which for me, it's again organ motion, because it's the variation in the anatomical variation, which are related to the changes in shape and position and feeling of the gastrointestinal organs, which is something which is really important for abdominal treatment, particularly for pancreatic cases. So here is one of our pancreas tumors, and this is the planning CT. And here is a pre-radiation therapy evaluation CT. And you see that you have a variation in the stomach and a significant variation of air filling in the bowel. Here is another evaluation CT, and the air filling is again different. We don't have a gantry, so we are left with the fact that we cannot use beam directions which are crossing the bowel, because this is, let's say, the dose degradation from this direction would be significant. And this has been shown in several publications in the literature. So here it's what happens interfraction, so days from days. But this is not something that changes that changes on a daily basis. This is something that changes on a minute basis. So it's a problem that we also have intrafraction, not only interfraction. And it has been shown from the group of, I keep on calling it NIRS, but it's QTS now. So the group from Chiba. And they studied for 10 patients the variation of the air filling in the bowel and the gastrointestinal organs, acquiring CTs at 0 seconds, 35 seconds, and 145 seconds. And they did dose recalculation on the on every CT. So this was the planning CT, and then did dose recalculation, and they could demonstrate that even in an interfraction basis, you can have dose degradation due to beam overshoot or undershoot, as you see from the arrows here. Maybe you don't see it from the isodoses, but here there's overshoot and undershoot. Overshoot inside the organs at risk and undershoot here in the tumor. So what can we do? Well, one option is beam selection, as I was saying before. There are this has been studied both in Gunma and in Heidelberg. In Gunma, they have only passive system, so they cannot really well, on-light adaptation, it's an issue for all carbon ion facilities, but it's even more an issue if you have a passive system, because you need beam-specific systems that you have to mechanically produce. So what they're doing is basically to prepare a series of beams, which are spread on 20 degrees around the planning beam with a step of 5 degrees. And they, based on the daily imaging, they're choosing the best option that they can deliver, that best option with the criteria of target coverage. While in Heidelberg, they have a gantry in Heidelberg. Here, I think they obtained this orientation with the cradle, so or turning the patient. While in Heidelberg, they have gantry, and they studied which was the best beam direction, and they concluded well, something which could be obvious, but it was also concluded by the study before. I forgot to mention, sorry. Here they concluded that the worst was the beam, the worst in terms of uncertainty in target coverage was the anterior beam and the beam coming from the left, which was the same conclusion from the group of Heidelberg. They studied different approaches, as you see from the arrow, with multiple beams or just one beam. And this one is just the anterior beam, and this one is the beam coming from the left. So not from the liver, but from the other side. And here you see these large bars are the volume receiving 95% of the dose, the volume of CTV receiving 95% of the dose. And these two options are the anterior and beam from the left. And here's the same, is the homogeneity of the target dose. Those are the worst. So it's intuitive, but it has also been demonstrated in different studies. Sometimes you don't really have an option. So what we are doing, not having a gantry, not having a cradle, is if we cannot obtain a good plan from the back with the patient prone and with the vertical beam and the beam coming from the liver, we try to use a second positioning of the patient, supine, and with an anterior beam and another beam coming from the liver. So ideally, you would like to know how is the organ filling on a daily basis and immediately, possibly immediately before starting the treatment, as we do with conventional radiation therapy. We use combine CTs. Unfortunately, combine CTs are not that available in carbon ion centers, and anyhow, the quality of the image quality is still not good enough to do a plan recalculation, online plan recalculation. Here they have been used for retrospective analysis and a comparison of the dose robustness against different organ fillings between photons, protons, and carbon ions. And again, they concluded that with photons, yes, it's important, but photon radiotherapy is highly robust against interfractional anatomical changes. Why they found those variations in target coverage higher than 10%, but it can be even higher for particle therapy. And then my major issue. So what is the major issue, in my opinion, when you're treating abdominal tumor and particularly pancreas tumors? My personal nightmare is the duodenum position. So here is one of our cases that has been treated with a neoadjuvant protocol. So it was 8 fraction, preoperative 8 fractions of 4.8 gray RBE. We acquired several 4D CTs of the patient, and the orange line is the CTV, the red line is the GTV, and all the rest is the duodenum as acquired at different times along the treatment before and along the treatment course, and then registered on the planning CT. So as you can see, it can be everywhere. It can be even completely inside the target volume, not inside the target volume, but in the place of the target volume, in the original position of the target volume. So this part is receiving the full dose. We even tested, for 9 patients, we tested a PRV approach. So we basically used the acquisition, the first 2 acquisition before treatment start. The union of the duodenum contours, we apply a PRV of different margin expansion from 0 to 10 millimeters. And we checked with an intersection over union approach to see if the PRV of the pre-treatment duodenum position would be able to predict the position of the duodenum during treatment, but this was not possible, not even with a 10 millimeter margin expansion, which would of course completely cover the CTV and completely destroy the target coverage. So what we are doing now, when we do this, when we treat this patient, it's what I skipped before. We are doing all the robust optimization that I said, and we are also including in the robust optimization different anatomical scenarios. So we do more than 1 acquisition before treatment, and we use the maximum exhale and 30% inhale, and the maximum exhale of a second acquisition after a few days. And then while we go on, we include different scenarios in the robust optimization. On average, on these 10 patients, this hasn't been demonstrated significantly better than the normal approach. But if you see on a patient-specific basis, the blue line is doing nothing. So just reevaluating the patient without treatment adaptation. The red line, it's for each patient, this is target coverage, CTVD 98%, and here is the duodenum dose. The red line, it's the approach of using multiple anatomical scenario in the plan optimization, and the green line is it's an ideal daily adaptive treatment. And each point, it's a different evaluation during the treatment course. So on average, it was not significant because the patient pool was very small. But if you see it on a patient basis, it was able, the multiple anatomical scenario approach was able to recover target coverage and also to minimize duodenum dose in more than 1 case. And okay, the drawback of this offline adaptation protocol is that this is a study that was recently performed by a colleague of mine and a visiting student, and we verified that for 485 patients treated in 1 year, we had the number of replants. The majority of the replants were for head and neck cases, but this is because the majority of our cases are head and neck cases, and then the rest was in the abdominal region. And these ones are the ones who are replanted more than once along the treatment course. And with this, I thank you. I don't know if I'm on time or off time.
Thank you very much. Yes, of course. And so let us see if we have questions in the shared document first.
Okay, I'm going to share my screen.
Yeah, I want to stop my, okay.
Yeah, thank you.
Sorry.
Perfect. Okay, just one question. On CT image used for planning, do you use the average?
No, we use the maximum expiration.
Okay, thank you very much.
Let's see if we have somebody that wants to raise hand and ask questions. Or if you wish to continue typing in the shared document as you prefer. I do not see any raised hands and nothing in the chat.
We don't have any more questions in the document as well.
Okay, thank you very much. Then we thank the
You're
speaker